Hello everyone, my name is Ernest Popropek and I am the participant of 2020 edition of Robotics Institute Summer Scholar Program at Carnegie Mellon University. Together with Senior Lee, under the mentorship of Dr. Artur Dubrovsky with the medical help and support of Dr. Michael Pinsky, I want to present you the results of our work on dynamic differentiation between hemorrhage and sepsis. So first of all, what is hemorrhage? As you may have noticed, it is simply the process of blood escaping the circulatory system. It can happen either internally or externally, for example due to traumatic incident. As external bleeding might be easy to notice even for those not medically skilled, with internal one the situations require higher medical suspicion and various diagnostic methods. Sepsis, however, is slightly more complicated. It is a critical medical condition which happens upon bacterial infection causing the immune response of our body to cause actual injury to its tissues and organs. Its presence is usually diagnosed by testing whether endotoxins, that is lipopolysaccharide (LPS for short), the outer membrane of the cell wall of gram-negative bacteria, are found in the blood. Their presence then triggers the septic reactions. The problem lies in the very beginning of both of the medical conditions, as they both manifest themselves with drop of the blood pressure, from which alone it is hardly possible to differentiate between using current approaches. They do require a vastly different medical treatment, as untreated might lead to very serious consequences. Some grim data regarding those two phenomena: healthcare-acquired infections kill 1.7 million annually just in the American hospitals alone. It is worth to mention that this problem is related also to so-called superbugs, that is bacteria which is resistant to antibiotics. Consequently, 2 million people worldwide die from hemorrhaging, as they do not receive the necessary treatment on time. So how can machine learning help in medical diagnosis? Clinicians are being stormed with vital sign measurements, and such information may be either underestimated or simply too complicated to quickly analyze. Machine learning models might serve as a great support for clinicians, as our computers are much better than us in analyzing huge streams of data. Previously, few approaches of detecting hemorrhage with machine learning have been described. One study presented convolutional neural network being able to detect different types of intracranial hemorrhage based on CT scans of human head. This approach outperformed some of the professional radiologists in accuracy of detecting this medical condition. Other group of researchers presented a model being able to dynamically detect hemorrhage using CVP, outperforming previous approaches addressing this problem in terms of speed of detection and providing a better foundation for further evaluation of patients' health for clinicians. As I mentioned earlier, sepsis is more complicated reason behind hypotension. Its adverse outcome is the septic shock, which when sepsis leads to life-threatening low level of blood pressure and abnormalities in the cellular metabolism. There are great studies utilizing machine learning to predict both sepsis and septic shock, reaching useful performance prior to the condition's onset. However, most of them are either supported with data out of scope of the vital sign measurements or have foundations in a relatively long time of monitoring the patient. To our knowledge, there is no currently a reliable, automated and dynamic solution differentiating between the two medical conditions. Mostly methodology of eliminating possibilities is used. For example, during a septic shock, major blood loss from gastrointestinal hemorrhage is uncommon, so when facing such events, our intuition might lean towards diagnosis of internal bleeding rather than sepsis. For this study we used an animal laboratory dataset containing of 23 pigs. 15 of them were exposed to bleeding of 5 ml per minute pace, and the remaining 8 into 2 infusions of the lipopolysaccharides. First one to destroy the immune system and the second one to develop septic reactions. Before this, they were stabilized for approximately 1 hour while their vital signs were measured. For each peak we calculated the statistical features. Mean, median, and the range between 5th and 95th percentile corresponded to different denoising techniques on the waveform, so we have an absolute magnitude of the measurement without the unnecessary noise. Standard deviation shows us how prompt were the changes in subject's body. Furthermore, discrete Fourier transform has been used as it has this nice property of showing how much given frequencies contribute to the overall signal. For chosen bands, we calculated the corresponding band power, of which most important is the second and third one, consequently corresponding to respiratory and heart rate. As it was calculated for time windows, the data has been downsampled to 2 Hz. The last task of data preprocessing was to overcome the problem related to episode selection. This is caused by the selection of the second episode of LPS infusion, which is not immediately following the stabilization period, contrary to the group exposed to hemorrhage. This resulted in differences in such transitions, which interfered with the predictive power of our model. To overcome this, we decided to trim the training data. Furthermore, the data for each peak has been standardized using a stabilization phase. Given a feature of arterial pressure might be calculated as original value of the feature minus the median of this feature from the stabilization period divided by the interquartile range of this feature in the stabilization phase, as shown in the equation. For this experiment, we marked the LPS infused group as positive class and bleeding ones as negative. Training has been performed using specific applications of cross-validation. For each training run, we selected 2 peaks from opposite classes to test the model on. This resulted in training on data of 21 peaks and testing on the chosen pair for each fold. This process has been repeated 120 times. Looking deeper into single folds of cross-validation, first we truncate the training data to fit only 25 to 40 minute time interval. We've done this to avoid instabilities caused by episode selections, which may bias the model toward learning individual differences between the peaks rather than differentiating the 2 medical conditions. Testing on the chosen pair was done for whole duration of the episode without any truncation. For the model, we decided to use the Random Forest Classifier with constrained number of decision trees and maximum depth of each tree to prevent possible overfitting with such small group sizes. The average ROC was calculated by accumulating all the false positive ratios calculated at each fold of cross-validation and then interpolating the point from each ROC curve made in the cross-validation for those accumulated ones. The model shows a decent predictive power even at low FPR values, which indicates that we may detect sepsis with notable performance, barely making any mistake. Similar situation with the negative values, that is the bleeding group. The metrics calculated for the overall performance of the model are satisfactory, with correct tendency of the model differentiating the 2 medical conditions. It is leaning slightly towards the hemorrhage group due to the fact that there are almost twice the samples of it in the dataset. The percentages of the confusion matrix correspond to the portion of original data that has been predicted as per indication of the matrix cell. Although the general performance of the model is important, in medical diagnosis for critical care we are especially interested in low false alarm ratio. Sometimes it is more useful to correctly identify only 20% without making a single mistake than having a model performing random guesses and detecting around 50% of the target. This confusion matrix has been calculated with probability threshold of 0.1, that is, if the model predicted probability larger or equal to 0.1 for a certain sample, it would classify it as a positive class and otherwise as a negative. For such calibration, the model makes only about 3 mistakes per each 100 decisions when detecting sepsis, given that it makes 2 predictions per second. Lastly, we performed the analysis of the feature importance to see how the decisions are made inside of the model. The importance of the feature is defined as how much it impacts the final decision. Correct or assumptions, the most important are those directly linked to the vital signs, respiratory heart rate with almost 30% each of importance. Consequently, very important is the standard deviation resembling the dynamics of our body response to the ongoing situation, for example sickness. Heavier the body, faster it responds. This study obviously has some limitations, but there are great plans ahead. We want to evaluate how other vital signs might help with decisive power of the model, not to rely only on the arterial pressure with possibility of finding less invasive measurement technique with similar or better performance. It would be worth to see how our approach performs on other data, including larger groups, eventually the data collected from humans in non-laboratory environments. Thank you so much for your time, and I would personally want to thank all the participants of this project for guidance, help and inspiration. Furthermore, I would like to thank all the sponsors for making this extraordinary experience possible. Thank you so much.